Hi there, my name is Tiffany Patterson. I'm an interventional cardiologist at St Thomas's Hospital in London and a clinical lecturer in interventional cardiology. I'm going to talk to you about cardiac arrest centres and their role in post-resuscitation care. I'd also like to thank the ERC committee for inviting me to give this talk. In terms of my conflicts of interest, I'm the PI at St Thomas's and the clinical lead for the arrest trial. So cardiac arrest centres effectively focus on post-resuscitation care, and it's the last link in our chain of survival. And the reason that cardiac arrest centres are important is because after a cardiac arrest, patients can suffer a post-cardiac arrest syndrome, which is effectively a result of hypoperfusion of all the major organs. And this includes brain injury after the cardiac arrest, myocardial dysfunction from not receiving any blood, persistence of the precipitating pathology, for example, an occluded coronary artery, and also the systemic ischemia reperfusion response. So once the cardiac output is restored and blood's recirculating, you get a lot of toxins re-entering the bloodstream. The extent of the post-cardiac arrest syndrome is very dependent on the duration and cause of the arrest. It can lead to multi-organ failure, as we said already, and can also cause seizure activity in patients who've suffered substantial brain injuries and also cardiogenic shock, which can be short-lived and can be treatable, but also can be a permanent effect on left ventricular function and cardiac output. So survival, certainly in London, and these figures are provided courtesy of Professor Fothergill, are consistently around 9%. If you look at the Utstein criteria, they're obviously much better at 32%, but there must be a way of trying to improve this, and focusing on post-resuscitation care might just be that. And it's very likely that by using a multidisciplinary approach, we should be able to improve neurological survival. And also, amongst different centres and within centres, we should be able to enhance our consistency of care. And by increasing provider experience, in other words, increasing the volume of cardiac arrests dealt with by a certain centre, we should be able to overall improve survival and reduce variation in survival. Also, the benefits include a reduction in burden to the cost. So regionalisation of care is one way of doing this, and certainly in ST elevation myocardial infarction this has worked very well. STEMI is a time-critical illness, so if you can treat it quickly and effectively, then you can improve outcomes and improve survival. The reason that we're focusing on regionalisation of care is that there is a lot of difference in survival, and there was a lot of difference in ST elevation MI. And there is now a lot of difference in survival in cardiac arrest and post-cardiac arrest care. And it could be, as mentioned earlier, by concentrating services and therefore increasing provider experience, that we might be able to improve survival. It certainly has improved outcomes in other time-critical illnesses such as trauma care and ST elevation MI. So, are cardiac arrest centres the answer? Well, I think it comes down to what is a cardiac arrest centre. And ILCOR recommends that post-cardiac arrest patients should be cared for in a cardiac arrest centre, but there really should be a minimum criteria for what a cardiac arrest centre is. And that includes 24/7 access to interventional cardiology facilities, which I'll focus on later and perhaps expand on a bit for you. The intensive care expertise, diagnostic imaging capabilities, and also standardised neuroprognostication, which is very important. So what do we know so far? Well, we know that if you're treated at a high volume cardiac arrest centre, your survival and long-term outcomes improved. We also know that increasing provider experience, so the amount of cardiac arrest or the volume of cardiac arrests that you see, also increases your chance of survival if you're delivered to a centre. We also know that delivering post-resuscitation care also improves your survival. It's also interesting to see that regardless of any of this, that there is a tendency for pre-hospital services to deliver patients to hospitals with PCI capabilities or the ability to manage temperature appropriately, because a lot of us do believe that this is a better way of managing them. And also, if you improve communication between your specialties, if you've constantly interacting, then you also reduce your time to treatment. But then we should also take into consideration that all of these studies are observational. And it may be that these patients who are faring better have better baseline characteristics that are more favourable for survival or survival free from neurology, such as being younger, presenting in a shockable rhythm, having less comorbidities. I'm now going to talk to you a bit about concentrating services within a cardiac arrest centre. So critical care is one of these examples. And as you know, they provide ventilatory, hemodynamic, renal, temperature management, glucose management in order to appropriately care for the patient following cardiac arrest so that they can be as stable as possible. VA ECMO is also something that's provided by certain centres and can help a lot in certain situations. Certainly radiology can help a lot because the ability to access diagnostic services means that you can diagnose reversible conditions and treat them. For example, an aortic dissection would need urgent cardiothoracic surgery, saddle pulmonary embolus would require thrombolysis, and you may need neurosurgical input as well. In terms of neurology, if patients have had substantial brain injuries, then they will need seizure control and appropriate neuroprognostication after 72 hours, ongoing physiotherapy, particularly if they've been an inpatient for a prolonged period of time, but also neurorehabilitation. So in terms of cardiology, we need access to the cardiac cath lab following cardiac arrest, not only because of primary PCI capability, in other words, opening up a blocked coronary artery that could have caused the arrest, but also for mechanical support. So in the cath lab, we can also insert percutaneous devices that can improve the blood pressure and improve coronary blood flow. Patients in asystole may need temporary pacing wires or emergency pacing services. And also echocardiography is required to assess the extent of LV dysfunction or RV dysfunction after a cardiac arrest. If the cause of the cardiac arrest could be a pericardial effusion or acute valvular regurgitation. And following on from that, following survival from a cardiac arrest, the ability to deliver or provide patients with defibrillators if necessary. So there's a variety of mechanical support devices that are available. The impeller device is inserted in the cardiac cath lab, and that's essentially a suction pump. So it sucks blood from the LV and ejects it into the aorta. It doesn't work if you don't have a cardiac output, but it does support your output. ECMO is almost like a mini cardiopulmonary bypass machine, and it oxygenates and provides circulating flow, and you can do that without a cardiac output. Balloon pumps again require a cardiac output with only marginal support of the blood pressure, but substantial increase in diastolic coronary blood flow during diastole, and they can also increase cardiac output during systole by the recoil. And other devices, such as mechanical CPR, can maintain a cardiac output for transportation or to perform coronary angiography in the cath lab, for example. Here's an example of a use of a percutaneous assist device. So this is a patient who presented with an out-of-hospital VF arrest. They went to their local hospital but were then transferred over to our tertiary centre. And this is a picture of the coronary arteries. This is the outline of the heart. Here you can see the defibrillator pads on the patient. And this tube, catheter, is injecting dye down the coronary artery. And where the dye stops, actually, this is thrombus, which shows there's no blood flow here. The patient does have a cardiac output, and they've also had a balloon pump inserted. as I mentioned earlier, a balloon pump can improve diastolic coronary blood flow, but also can provide some systemic support. Here we're ballooning and stenting the artery. This patient who is hypotensive on a dobutamine infusion. And here you can see the blood flow is restored down the coronary artery. As there was ongoing cardiogenic shock, unsurprisingly, due to the myocardial injury, an impeller was inserted. And this impeller is actually inside the left ventricle, and this tube here sucks blood out and it ejects it into the aorta. So here we've got two percutaneous devices, both an impeller and a balloon pump. This is another example, and this actually is a patient with no cardiac output who came to the cath lab on ECMO. So they experienced cardiac arrest. This was refractory to shock or medications, and so they were brought straight for coronary angiography. You can see actually here that the heart is fibrillating and the aortic valve isn't opening. In another view here, you can see that there's actually a very, very tight narrowing in the major artery down the front of the heart, known as the left anterior descending artery, and this is a likely cause of the cardiac arrest. So we treated this, we ballooned and stented it, and restored blood flow. And here you can see the artery is actually much bigger, and the narrowing has been treated. And after a single shock, they return to sinus rhythm. So there certainly is a place for emergency coronary angiography in cardiac arrest. So moving on to the guidelines, in the context of ST elevation MI following cardiac arrest, it's strongly recommended the patient go straight to the cath lab. And that should be treated like any ST elevation MI, regardless of whether or not they've arrested. If, however, they don't have ST elevation on their 12-lead ECG and their post-ROSC ECG, it's slightly less clear. And the guidelines currently recommend that only if they're hemodynamically unstable or you have a strong suspicion that the cause of the arrest might have been cardiac, for example, chest pain before, or a history of ischemic heart disease, then it might be more appropriate for them to go to the cath lab. Otherwise, there's no consensus on taking these patients direct to the cath lab without ST elevation. So the COAPT trial looked at coronary angiography after cardiac arrest. They looked at delayed versus immediate coronary angiography, and actually they showed no difference. But these were in patients who were hemodynamically stable. So anyone that became hemodynamically unstable actually crossed over into the cath lab arm and went straight to the cath lab. So it's likely that we already knew that hemodynamically stable patients without ECG changes probably don't need to go to the cath lab. So although this trial is useful and gives us some useful information, it's not really changing our management. On the flip side, actually, I think we do need an RCT for cardiac arrest centres, and I'm going to talk to you about the RCT we're conducting, because all the data on cardiac arrest centres are observational. And if you look at the observational data, there appears to be an increased tendency for survival to be increased by patients with favourable baseline characteristics, in other words, younger patients with shockable rhythm. Coronary angiography alone doesn't impact outcome, but it may do as a bundle of post-resuscitation care. But the other thing is that coordinating services between pre-hospital care, emergency departments, intensive care and cardiology can be very complex. So we need evidence. We performed a pilot study looking at expedited transfer to a cardiac arrest centre versus standard of care to prove safety and feasibility, which we did. And we're now conducting a wide-scale pan-London trial looking at cardiac arrest centres and if patients benefit from being delivered to a cardiac arrest centre preferentially over the standard of care, which is their local A&E. The aim of this trial is to determine effectively the best post-resuscitation care pathway. So where do the emergency services deliver these patients if they've arrested? And we have hypothesised that changes to this pre-hospital care, this emergency management, which includes delivery to a cardiac arrest centre, will reduce mortality in patients. And this is patients without ST elevation, because patients with ST elevation do need to go to a tertiary cardiac centre. What we don't do is dictate what happens to the patient when they arrive at the centre. So in this trial, patients have to be over 18, with return of spontaneous circulation, having experienced an out-of-hospital cardiac arrest, and without ST elevation on their 12-lead ECG. And we're looking at all-cause mortality at 30 days and also neurological outcomes. We're running this trial in collaboration with London Ambulance Service, and there's a consent waiver in place for these patients due to reduced cognition immediately post-cardiac arrest. And in the intervention arm, patients are being taken to a cardiac arrest centre, and in the control arm, they're receiving standard of care. This is running in all centres across London. And up until February this year, we'd recruited 596 patients. Unfortunately, recruitment was paused due to COVID, but we're restarting on the 4th of November. And we aim to have a sample size of 860 patients with 430 in each arm. So, in summary, we know that bystander CPR and early defibrillation is key, of course, in cardiac arrest. And we know that cardiac arrest with ST elevation MI on the post-resuscitation ECG should definitely go to the cath lab. What we hope to know, particularly from the arrest trial, is if patients should go straight to a cardiac arrest centre or if they should be managed as they are currently, which is direct to their nearest A&E. And the arrest trial will help determine the best post-resuscitation pathway for these patients. Thank you for listening, and I appreciate it. Thank you very much.